More specifically, let's talk about learning objectives. By the end of this presentation, participants will be able to name the most common wrist complaint and wrist injury in tennis players, outline useful clinical tests for this patient group, and to start to understand the importance of different variables in tennis when designing a return to play plan. Tennis participation is on the rise. I can't see, but hands up, who here plays tennis? Online and in amphitheatre. Raise your hands, don't be shy, even if you hit a couple of times. That's still considered participation. Not bad, not bad. Oh, yes, no. Who treats tennis players? Raise your hands, who treats tennis players? I hear that Emir is a good tennis player, so somebody must be treating his tennis-related complaints from time to time. Though we may be losing him to paddle these days. I love this picture because not many sports can be played across the lifespan, and tennis does offer this opportunity. The health benefits of tennis have been well established, and people who recreationally play tennis live an average of 9.7 years longer than they would have otherwise. So if this doesn't motivate people to play, I don't know what will. At present, there are 87 million tennis players registered to be playing across the globe, and the International Tennis Federation, who's the governing body for tennis, projects that 120 million people will be playing tennis by 2030. They're investing money in programs, building infrastructure, creating more competition events, creating more opportunities for people of all abilities and backgrounds to be able to play, which means that you will be treating more tennis players in the near future, if not already. A little bit on wrist injury epidemiology. The rate of wrist injuries per 1,000 match exposures is 5.68, and this was taken from a study of tennis professionals, men and women combined. In terms of prevalence, based on the study from Wimbledon Championships, and the picture you can see here, wrist injury is the second most common injury in women, reported as 12% of all injuries, and the fifth most common injury in men, reported as 8% of all injuries. Although not as common in men, and more common in women, the average time to return to competition is longer than other typical tennis injuries. And I confirmed this was the case in the 2022 to 2023 season at the LTA when looking at our unpublished injury data. The prolonged time out from competition can really derail a player's professional career path, as demonstrated by players such as Emma Raducanu, Dominic Thiem, and Karolina Muchova. For those of you who don't know tennis, these are all former top 10 players who were sidelined for almost a full season due to wrist injury alone. And Thiem, in the middle there, has announced his retirement at the end of this year, stating as one of the main reasons that his wrist just doesn't feel right still, despite years of recovery. Undoubtedly, the most common wrist complaint in tennis players is ulnar-sided wrist pain, more specifically dorsal ulnar-sided pain, as seen in the picture here highlighted in green. This is evident in literature as well as within the cohort of elite tennis players where we've collected data over the past decade. When it comes to specific structures, the extensor carpi ulnaris tendon is the most affected structure, followed by TFCC, then ulnar impaction syndrome associated with the ulnar styloid process. That is on the ulnar side. Then we have dorsal wrist pain along the joint line of radiocarpal joint. That's the second most common area of wrist complaints in tennis players, as seen here in red. And this is where pathologies such as joint synovitis, ganglia formation, and or bone impingement due to abutment of the carpal boss against the medius can occur. Think of doubles players who are at the net having to reactively block tennis balls coming at them up to 200 k's an hour. They often present with dorsal wrist synovitis or a chronic impingement type picture. Finally, radial side wrist pain is nowhere as common anymore in tennis players because over time the grip position has changed, and I'll explain that later. But on the radial side, we can encounter intersection syndrome, de Quervain's, and rarely scaphoid fractures from falling on court, the odd ganglion from time to time. So if a player is coming to you with a wrist complaint, it's most likely to be ulnar-sided wrist pain, and it will likely have something to do with ECU tendon. In order to better understand ECU injuries, I will briefly review its anatomy. So the ECU tendon is located along the dorso-ulnar aspect of the wrist and passes through the sixth extensor compartment of the wrist, inserting into the fifth metacarpal base. The extensor retinaculum acts as a pulley, preventing bowstringing of the ECU tendon. And deep to the extensor retinaculum, the ECU is enclosed in a fibroosseous tunnel lined by the ulnar head and ECU subsheath, which holds the ECU tendon within the groove of the ulnar head. The ECU muscle is an important stabilizer of the distal radio-ulnar joint, and apart from its action of ulnar deviation, it also contributes to wrist extension in supination and flexion in wrist pronation. Also, the relative stability of the ECU tendon in the ulnar groove also depends on the forearm position. In full pronation, the tendon is within its groove, and in supination, there is greater tension of the tendon against the subsheath, as seen here on the right-hand side picture. As I mentioned, technique of the ground strokes has changed since about the late 80s, early 90s towards favoring topspin shot making, meaning the racket has to get under the ball before contact to create spin on the ball. And to achieve this, the way players hold the grip has changed from Eastern towards semi-Western or Western grip to allow them to get under the ball, which in anatomical terms means achieving forearm supination, wrist extension, and ulnar deviation, and from there going into pronation, flexion, and radial deviation. Here is a typical topspin forehand in slow motion. Controlled, it's at a hip height, doesn't look too extreme, she's executing it well, it's okay. But potential problems can happen when the ball is out of position, when the player comes to the plate, when it has to slide, which has to maneuver with the wrist to direct the ball. So that's one. On the backhand side, this isn't in slow motion, but have a look at how fast her racket head acceleration is once she starts lowering that racket on the take back. You can hardly see the racket head motion. In both videos, as I said, the ball is fed in a very controlled way. And so this repeated action back and forth with the tendon storing and releasing energy while traveling in this small tunnel for thousands of repetitions per week can lead to different kinds of pathologies within and around the tendon, especially if a player is more wristy on their shot and not transferring their body weight forward, and the wrist is playing catch up to achieve accurate ball placement. In those players with double-handed backhand, the injury can occur to either wrist. In my years of experience with elite British players, more injuries happen on the backhand stroke and more so in the player's non-dominant wrist, but can also occur in the dominant wrist as well, and it can also occur on the forehand stroke. So no rules, but it seems that the backhand is more affected generally and the non-dominant side. ECU tendon pathology can range from chronic tendinopathies to a more acute tendon rupture and instability, and they are not necessarily mutually exclusive. Repetitive nature of hitting forehands and backhands thousands of times per week can lead to development of tenosynovitis of the tendon sheath. I don't need to go into details of tendinopathy. I think we all know what it is and why it happens. But a tennis player is subject to so many variables week in, week out, from changing weather, court surface, ball pressure, changing hitting partner, changing coach who favors maybe basket feeding and technical work with less recovery time between shots. All these things can contribute to reactive tendinopathy, and this is a common occurrence. Instability of the ECU tendon within its subsheath can result from an acute subsheath rupture due to sudden forceful contraction of the ECU with the wrist in ulnar deviation, supination, and flexion, like the picture here. It is also worth mentioning that tendon ruptures can occur. This is very, very rare among tennis players, and there are case studies in literature associating repeated corticosteroid injections into the subsheath, which can cause weakening of the ECU tendon and eventual rupture if return to play is rushed. I'm aware of one professional wheelchair player who had a similar history and similar interventions, The rupture was irreparable, and he took a good 9-10 months to return to competition, having had to fully change his technique and follow through on the forehand. But these can be career-ending injuries, and for those reasons, I really think that cortisone injections should be used sparingly for ECU pathology, and that rehabilitation return to play should not be rushed. So with a player presenting with a suspected ECU problem, I want to know as a clinician, is it stable within the subsheath and compare it to the other side? Is the tendon itself structurally okay? And what is its current load capacity? Is there any tenosynovitis which may require anti-inflammatory treatment at the start of the rehab journey? Have a quick sip. Okay, on to clinical assessment. And for the sake of timekeeping, I'd like to focus on some key elements of assessment and some tips with ECU tendon injury in mind, rather than go through the whole routine examination procedure, if you don't mind. In terms of active range of motion, supination gives me a lot of information, but not the usual way that I see a lot of people measuring supination, like this to the left. I'd like to see that patient gripping something shaped like a tennis racket handle, because the amount of supination range they can create with a grip is so much greater. So this is the same person. Have a look at this comparison. That's like 40 degrees more. In the second video, supination range is influenced by carpals and the MCP joint glides, but this is, I believe, a bit of an adaptation to playing tennis, as it mimics how they hold their rackets when hitting ground strokes. And so assessing supination range of motion this way adds value to the assessment. You know, are they free? Based on the screening and injury data collected on elite British tennis players, healthy wrists have about 95 degrees of supination range, and as much as 130 degrees on the dominant side, so on their forehand side, and on average, about 10 degrees more on the non-dominant side if they are a double-handed tennis player. So that's just from the screening data that we have. Here are some provocation tests for suspected ECU tendon or subsheath pathology. I won't go into details of each one, but the Hayton, Koo, and Evans paper provides a good summary of these tests. The ECU synergy, the ice cream scoop, and the Cobra tests look at tendon instability, but all of these tests can provoke pain in patients with an acute ECU injury. The last two tests in grey, we've developed in-house. They may exist already as well, but we find them useful at mimicking, again, the take-back position on a forehand or backhand, going into extreme range of combined supination and extension, both actively and passively down here. And we found them to be good clearance tests for returning to hitting. If they're not clear, we are going to be slower, just in our experience. If ECU pathology is suspected, the use of imaging helps confirm the diagnosis and the extent of the pathology. Dynamic instability of the ECU tendon relative to the ulnar groove can be identified with an ultrasound scan. To identify subsheath pathology, T1 weighted MRI scan with gadolinium enhancement is thought to be the most accurate. In terms of tenosynovitis and tendinopathy, both ultrasound and MRI imaging are good. However, MRI is the imaging choice for visualizing the TFCC, reactive bone edema in the ulnar groove or styloid. And let's not forget other ligament injuries such as ulnotriquetral ligament, etc. So, once a working diagnosis has been established, just like with every injury, I want to know as a physiotherapist, what stage of rehabilitation is the player in, and therefore when can they start active rehab? What is their current level of wrist function, and what is their end goal? How much load can their wrist handle locally, but also globally, to help work out when they can resume upper body training to minimize deconditioning? Have all risk factors been identified, and will they be addressed in this block? For example, apart from the usual objective measures that we take in the clinic, has a coach identified a technical inefficiency that may have led to this problem in the first place, especially if it was of gradual onset in nature rather than a one-off shot? Tennis being a skill-based sport, especially when it comes to professional and semi-professional players, we need to think about reinstating hitting on court as soon as it is safe to do so. For example, if their non-dominant wrist and therefore the backhand is affected, they can resume hitting forehands as soon as their pain on the other side is under control with at rest. And the affected wrist can be put in a brace to protect it against accidentally hitting the ball. And so that's one way of modifying it and allowing the player to get back to hitting very soon. Of course, not every case is like that, but just something to keep in mind. Skill-based sports, try and get them back to some kind of activity on court, modified as soon as possible. So once we have all the information we need, we plan a 4-phase return to play plan, which over time we've summarized as the following, because the player's only question is always, when can I play again? So we've named each phase relative to hitting. And so phase 1 is your typical recovery phase. Phase 2 is reloading the wrist and hitting prep phase. Phase 3 is tennis reloading phase, where we progress them through shot counting while they work through a strengthening block. And then phase 4 is return to normal training and pre-competition exposure. We used to have a phase 5, which was called a pre-competitive phase, which all looked very pretty, and everything was beautifully done and it all made sense. And it was where players spent the last week of return to play simulating a tournament environment, playing practice matches, and ensuring the players played 2 and 3 set matches on back-to-back days, so that we were really, really confident that they were ready to go. But the players refused to stay around for that last phase, which is usually a week, and preferred to go on the road and use their first tournament week as a stress test week. And we fought hard and we failed. So we've had to squash some of the match simulation into the back end of phase 4. But at least the players are on board with this type of plan. And I think psychologically having 4 stages instead of 5 feels quicker in their minds. So, interesting fact. Okay, I'll let you read. What I wanted to do was I'll present you with a case study to make my discussions about rehab a bit more meaningful when we have a player in mind. So we'll call our patient Joe. Here it goes. Assessment on day 1 with the doctor, assessment on day 2. Have a quick read. I'll give you a minute. And then I will take you through some return considerations. So right-handed tennis player called Joe, left wrist, left ECU tendon inside the meniscus and everything else intact. So that's what we'll work with. So here is a rough master plan of physio-led 4-phase return to play plan. We'll go into more detail over the next few slides. What I wanted to point out was that this is not a quick job. His tendon failed to withstand the demands of the game, in this case, 1 shot. There are tendon changes, and then there is inflammation. Many failed rehab plans are due to skipping a step or simply not providing enough strength stimulus to promote the adaptation, which in Joe's case would be tendon remodeling, which he needs. And once we get to phase 3, how many new variables around tennis loading have to be introduced gradually and with smart planning to minimize the risk of overload somewhere else. So this master sheet can be applied to most acute and chronic wrist injuries. I just wanted to give you a bit of an overview of what sort of variables we deal with, and I'll talk about it more as we go along. Just a quick master sheet overview. Okay, so Joe, phase 1, recovery, goals. You can read about the goals. So it's pretty straightforward, but with a splint to help settle his symptoms faster. It isn't uncommon to immobilize the wrist when inflammation and pain are present alongside a tendinopathy. Stops further aggravation of injury, stops awkward sleeping postures in bed, which could lead to unnecessary compression and irritation. Anti-inflammatories were prescribed, but I also find pulsed ultrasound of 3 megahertz with normal gel also helps shift any inflammatory fluid because it's a very superficial structure, the ECU, and you can see it, you can feel it around that distal ulna. So I think this is a useful adjunct to help just to help the swelling reabsorb if you add pulsed ultrasound treatment. And in this time, we spent time restoring his pain-free wrist range of motion. We began the basic isometric exercises, discussed return to play planning and goals. And on average, this phase 1 takes about 7 to 10 days to overcome when tenosynovitis coexists with tendinopathy. Phase 2 gets more interesting, where wrist basic reloading begins while also starting to prepare for basic hitting. Restoration improvement of basic hand and wrist function and endurance through various different stimuli, in case there was any muscle inhibition. The graph seen on the screen is Joe's typical week before competition, as captured by Catapult. So Joe can hit up to 3,000 tennis balls in 5 days in a week. Then he went off to tournament during this capture. So these players are used to hitting high volumes of balls and playing 15 to 18 hours per week. Therefore, don't be afraid to fill their time with high volume, low resistant exercises to keep the momentum, but also giving the player some benefits, by giving them a whole lot of exercises that they can work with within a pain-free zone. In this phase, the player can also commence push-pull exercises in the gym as long as the grip test, maximal grip test, is pain-free, as well as all other conditioning as able. He can also commence hitting forehands. Remember what we talked about? It's a backhand side, non-dominant, but actually there's nothing stopping him going out there and having a normal training session with his forehand as per normal. But I would suggest wearing the brace in the left hand when hitting, just so to not be tempted or to accidentally hit the ball unnecessarily. So that is phase 2. In terms of endurance-based drills, we're introducing flexion, extension, pronation, supination, radial ulnar deviation. We're also introducing rise drills to improve capacity in hand intrinsic muscles through time under tension drills. In addition, we commence upper limb perturbation and vibration drills, seen here in the bottom middle, to maintain bone turnover now that they are not hitting on that left hand. So you can see me on the middle picture there below, hitting the racket against the table edge as a form of racket vibration. And as I said here, we do low load and high reps. We do these sort of sessions twice a day. We have multiple exit criteria for this end of phase 2, which is all about restoring basic function, basic level of skill set, I need to have confidence as a therapist that the wrist is ready for a strengthening block, and for light tennis reintroduction of that left side as well. When the exit criteria are met on the right side here, it's time to move to phase 3. For me, phase 3 is the most important in terms of improving global hand and forearm strength, but also improving ECU tendon tolerance to withstand the demands of tennis. It's also the time to start hitting on court, but in a very controlled and prescribed manner and with low pressure balls, and I'll explain that as we go along. Also, this is the time to introduce any neuromuscular retraining or coordination work up the chain with med ball throws, with the aim of reducing pressure on wrist and hand muscles while learning to load the legs more. So this is the stage when you can start to catch med balls and with confidence, knowing that the pain has settled and you've got enough capacity to do that. Strengthening block is normally done 3 times a week without tennis to start with, to ensure that the variable of weight training that we're introducing specific to the hand wrist is not aggravating the wrist, logically. Here we have wrist extensor and pronator group. Also do ulnar deviation. I didn't get to touch that in the video. We start with 3 sets of 12 repetition max. Then we progress to 4 sets of 12 repetition max, then 4 sets of 10 RM, go down to 4 sets of 8 RM time. We also start heavy isometric strengthening for ECU and the hand muscles by performing walks with different weights in hand. So this guy here, oh, the video is cut it, but you can see it. Anyway, the bar is off center, it's longer at the back, it's weighing him down and he's trying to keep it leveled. That's 20 kilos heavy. And he does 3 sets of 30-second walks. And that exercise is really, really good. It really gets that ulnar side, all of it working. Yeah, farmer's walk, great exercise. Now, by adding the other 2 walking exercises, we're covering strength across the wrist, sort of from all angles, grip strength is. And for tensile loading, we're targeting isometric strength at least 3 times a week at 30-second holds, 5 sets. Once gym has commenced for at least a week, the player can start hitting lightly the backhands with sponge balls to a prescribed dose, provided the windmill test is negative. You remember the windmill test is like a windmill. I called it the windmill. From 12 o'clock to 6 o'clock, you're really twisting, you're compressing it down there, but you're going into that supination back out of really testing, because that is the take back position that they're going to get into. So if they can't actively do it on their own and they can't shadow that shot pain free, then they're not ready. But if they can, and if this is clear, then it gives me confidence that they can start moving the So busy slide, but I'll talk you through it. Returning to backhands is progressed through 4 variables when we talk about returning on court. We have ball type, we have zone of movement, we have level of predictability, and we have number of shots, which eventually turns into a time limit once a target of 300 backhands has been hit. Because remember, the player hits up to 3,000 balls per week. So we need to start somewhere and we need to build and build and build. Now, tennis balls, they differ between those used by children versus parents. The lower pressurized balls are softer, they don't bounce as well, and equally don't travel as far when hit, which means the player cannot hit with top spin that much, which is great. They hit more flat, they get a little bit of, obviously, contact, they're starting to feel good. It's protected. It's a nice way to start getting back into the backhand. So we don't start with a normal ball, we start with a low pressure ball, normally a sponge ball. If there's no sponge ball, then red ball is the next one up. And they go from sponge ball to orange to green and then to normal ball. Now, the whole process to get to normal ball can take up to 4 weeks. Which gives the gym-based strength work enough time to create a meaningful change in and around ECU tendon in terms of strength gains and therefore better adaptation to load. So that's why they work hand in hand together. That's why phase 3 looked like a busy slide of kind of 2 components, but they can run parallel to each other because we're not pushing the backhand maximally, and we're practicing the skill, gradually building up, but we've got the strength parallel running alongside it, and they eventually both make gains and they both meet at the end of phase 4. Now, moving on to movement zone. So you choose the ball, then movement zone. Okay, it refers to how much movement should take place during training. For example, zone 1 means they don't move. They stay static and the coach just throws them a ball to hit, for which they only use their arm and wrist. So think lower limb injuries where they're not allowed to maybe weight bear, but they want to practice their skill. So zone 1 works well for lower limb injuries, but it's a disaster for upper limb injuries because we don't just want them to use their wrist, we want them to use their whole kinetic chain. So we skip zone 1, but they start from zone 2, which is 1 step to shot for drilling and for hitting, and this is what it looks like on the video. So just a little split step, 1 step to shot, no more than that. Controlled, predictable. That's their starting point. In terms of predictability, all drills and hitting needs to be predictable until movement zone 4 is reached. So that's how we stretch out. Again, training week. Remember, I showed you his training week in terms of how many shots he gets to hit in a week, as measured by catapult device. So about 3,000 shots, combination of forehand and backhand. Therefore, we use that as a target to build up to, and then we start building shots more and more. Of course, we follow the A to C acute to chronic ratio principles to make sure we don't overload, and we slowly build and build number of balls. And I think this is people who don't work enough with tennis players, and then they see a tennis player. I think this is where a lot of people go wrong, or a lot of practitioners go wrong, because you check their range of motion, it's good. You check their strength, it's good. Yeah, this all seems good. Okay, now you can go and practice. But the practice can be wild, and it's really important. There's one thing I can stress. Please try and use some of these principles to start with a softer ball, to start in a more confined space, to give them a number of shots to target with plenty of rest in between, just to control it so that it doesn't go haywire, and so that they don't overload. So that's, if there's one thing you can take away from me, I would strongly encourage you to adopt some of these principles. So what else did I want to say about this? Yeah, obviously not everyone has wearable technology. This was nice to capture, but as a general rule, based on experience so far, counting up to about 300, again, for someone who trains 15 to 20 hours a week, counting up to 300 is okay. And after that, switch to 300 backhands in a 90-minute session is how much roughly it happens, in a normal environment. So that's why I'm saying the counting to about 300. Once they hit 300, then you can say, right, well, go back to your normal training hour and a half, and then build up time that way, and then that transition will be smooth. So you can do it without wearable technology and still be effective with it. Okay, and then phase 4 is about the player being back in their normal training environment, getting ready for competition while continuing to do hand and wrist exercises in the gym. So continuing that strength program. A successful return to competition is one where the player is pain-free on backhands, they have returned to their normal training hours and can play practice matches comfortably. They're strong in the gym, have good grip strength, and are lifting 20 kilos or more with regards to the grip-based strength, all those walking exercises. This is what I would expect with someone like Joe. And again, this is coming from experience, and some literature supports it. Grip strength in tennis players, a desirable one. For men, 50 kilos and more. For women, it's 40 kilograms or more on that maximal grip strength test. So that's what I'd love to see in this phase 4, to give me the confidence to say, look, you've done a good strength block. You are strong. You should be able to tolerate your load. We've built up gradually. You should be good to go. If, however, the symptoms persist, then it may be worth looking at the technical execution of the backhand. If the program was progressively followed, if everything was good, maybe the missing link is something biomechanical, technical, which no matter how strong you are, if you are not executing well and over using your wrist, then you need to stretch that part out and get better at it. Either that, or have we missed something else underlying there that wasn't maybe picked up on a scan. But if these things are done well, there is a good chance that they will, and they've built up well, there's a good chance that they will go on and not have a problem again. And they will have learned along the journey about peaks and troughs, and not overloading too much and gradually building up. So it would have been a good learning journey. So we've had lots of success following this pathway. And what else did I want to say about this? Yeah, so again, sure all the pain provocation tests are negative, which they do become Some of them, usually the weight bearing one can take a little while, but again, all of the provocation tests are clear by the time they're ready to go and compete, in my experience. They should be in that last phase, they should play practice matches on back-to-back days to give you as a clinician and then the confidence that that can be achieved in a controlled environment before being released into competition. And obviously very important for them to maintain the gains in the gym and condense the strengthening program, still take it on the road and still do something to keep the stimulus going. So just a recap of the key learning objectives for today. Most common risk complaint in tennis players, I hope you know it by now. Useful clinical tests for this patient group, I hope you've learned, and understand the importance of return to play planning using different variables. Thank you very much.